In the previous lecture, we discussed the two non-selective direct-acting adrenergic agonists, epinephrine and norepinephrine. Now let's move on to the remaining direct-acting adrenergic agonists. Unlike epinephrine and norepinephrine, these drugs are relatively more selective for specific adrenergic receptors. In this lecture, our focus will be on the alpha adrenergic agonists. We'll discuss drugs that selectively activate alpha-1 receptors, drugs that selectively activate alpha-2 receptors, and a few drugs that stimulate both alpha-1 and alpha-2 receptors. As we go through each drug, we'll first understand its receptor selectivity and mechanism of action, and then see how that underlying physiology explains its clinical uses and adverse effects. First, let's discuss the drugs that act selectively on the alpha-1 receptors. Before we discuss the drugs themselves, let's quickly recall what happens when alpha-1 receptors are activated. As we learned earlier, alpha-1 receptors are predominantly located on vascular smooth muscle. When these receptors are stimulated, they cause vasoconstriction of both arterioles and veins. Arteriolar constriction increases total peripheral resistance, while venous constriction increases venous return. As a result, both systolic and diastolic blood pressure increase, leading to an overall rise in mean arterial pressure. Since both systolic and diastolic pressures rise together, the pulse pressure usually remains almost unchanged. So instead of simply memorizing these effects, let's apply them to a tracing and see how alpha-1 receptor activation changes blood pressure and heart rate in real time. In the previous lecture, we learned how to interpret cardiovascular tracings. I highly recommend watching it first, as it will make today's concepts much easier to understand. Imagine this tracing represents a person's baseline cardiovascular status. The middle line represents the mean arterial pressure, while the peaks and troughs correspond to the systolic and diastolic blood pressure. At the same time, the distance between two consecutive beats tells us the heart rate. Now suppose we administer an alpha-1 agonist such as phenylephrine. Since alpha-1 receptors are present on blood vessels, not on the heart, the immediate effect is vasoconstriction. As the blood vessels constrict, total peripheral resistance increases, causing the mean arterial pressure to rise. On the tracing, you'll see the entire blood pressure waveform shift upward, reflecting this increase in blood pressure. Although both systolic and diastolic pressures increase, the difference between them, that is the pulse pressure, remains almost unchanged. Why? Because alpha-1 receptor stimulation constricts both arterioles and veins rather than selectively increasing cardiac output. As a result, the entire tracing moves upward without significantly widening or narrowing the pulse pressure. How can you recognize this on the tracing? Simply look at the vertical distance between the systolic peak and the diastolic trough. If that distance becomes larger, the pulse pressure has increased. If it becomes smaller, the pulse pressure has decreased. But in this case, the distance remains essentially the same. The entire tracing is simply shifted upward. That tells us the pulse pressure is largely unchanged, even though both systolic and diastolic blood pressures have increased. Now let's think about the heart rate. Since the heart has very few functionally significant alpha-1 receptors, the drug itself does not directly change the heart rate. But does that mean the heart rate always remains the same? Not necessarily. Remember the baroreceptor reflex that we discussed earlier. A sudden rise in blood pressure activates the baroreceptors in the carotid sinus and aortic arch. These receptors send signals to the medulla, which responds by increasing parasympathetic activity and decreasing sympathetic activity to the heart. Consequently, the heart rate slows down, producing reflex bradycardia. On the tracing, this is seen as an increased interval between successive heartbeats. Now that we understand the physiological effects of alpha-1 receptor activation, let's discuss the selective alpha-1 agonist, phenylephrine, sounds similar to epinephrine or norepinephrine. As we've just learned, phenylephrine stimulates alpha-1 receptors on vascular smooth muscle, producing vasoconstriction. This increases total peripheral resistance and consequently raises blood pressure. So at first glance, we might think that phenylephrine should be an ideal drug for treating hypotension. However, it's not that simple. Remember, vasoconstriction is a double-edged sword. While it helps increase blood pressure, excessive vasoconstriction can reduce blood flow to tissues and increase the risk of ischemia, especially in vital organs such as the heart. In addition, the sudden rise in blood pressure may trigger the baroreceptor reflex, leading to reflex bradycardia. Therefore, although phenylephrine can increase blood pressure, its systemic use is limited and must be used cautiously. Instead, phenylephrine is much more commonly used for its local or topical vasoconstrictor effects. One of its most common uses is as a nasal decongestant. During inflammation, the blood vessels in the nasal mucosa become dilated, leading to increased blood flow, swelling, and the feeling of nasal congestion. By stimulating alpha-1 receptors, phenylephrine constricts these dilated blood vessels, reducing mucosal edema and relieving nasal congestion. Phenylephrine is also used as an eye drop to produce mydriasis or pupillary dilation. Since the dilator pupillae muscle contains alpha-1 receptors, stimulation of these receptors dilates the pupil. Importantly, because phenylephrine does not affect the ciliary muscle, it causes mydriasis without cycloplegia. In other words, the pupil dilates but accommodation remains intact. One important clinical point to remember, although phenylephrine is usually applied locally, some of it can still be absorbed into the systemic circulation. In patients with hypertension, ischemic heart disease, or other cardiovascular disorders, this systemic vasoconstriction can increase blood pressure and potentially worsen myocardial ischemia. Therefore, patients with significant cardiovascular disease should use alpha-1 agonist-containing decongestants cautiously. The next important alpha-1 agonist is midodrine. Unlike phenylephrine, which is commonly used topically, midodrine is primarily used orally for the treatment of orthostatic hypotension, also known as postural hypotension. Midodrine is actually a prodrug, meaning that the drug itself is pharmacologically inactive. After oral administration, it is converted in the body into its active metabolite, desglymmidodrine, which is a selective alpha-1 receptor agonist. Once activated, as we discussed above, it stimulates alpha-1 receptors on both arterial and venous smooth muscle, producing vasoconstriction. Arteriolar constriction increases total peripheral resistance, while venous constriction increases venous return. Together, these effects raise blood pressure, particularly when the patient stands up. Suppose you're lying down and then suddenly stand up. Because of gravity, a significant amount of blood immediately pools in the veins of your lower limbs. This reduces venous return to the heart, causing a temporary fall in cardiac output and blood pressure. Normally, this drop in blood pressure is detected by the baroreceptors, which activate the sympathetic nervous system. The sympathetic nerves then stimulate alpha-1 receptors on blood vessels, causing vasoconstriction, especially in the arterioles and veins. Venous constriction pushes the pooled blood back toward the heart, while arteriolar constriction increases total peripheral resistance. Together, these responses quickly restore blood pressure, allowing adequate blood flow to the brain even when you're standing. Now imagine a patient with autonomic dysfunction. In these patients, the autonomic nervous system cannot generate an adequate sympathetic response. As a result, the blood vessels fail to constrict properly when the person stands. Blood continues to pool in the lower extremities, venous return remains low, cardiac output falls, and blood pressure drops significantly. Consequently, the patient may experience dizziness, lightheadedness, blurred vision, or even fainting, a condition known as orthostatic hypotension. This is where midodrine becomes useful. Since it is a selective alpha-1 agonist, it directly stimulates alpha-1 receptors on blood vessels, producing vasoconstriction even when the patient's own sympathetic nervous system is unable to do so. This increases vascular tone, improves venous return, raises peripheral resistance, and helps maintain blood pressure when the patient stands, thereby relieving the symptoms of orthostatic hypotension. However, this beneficial effect can also become a problem. Let's think about what happens when the patient lies down again. In the lying or supine position, gravity is no longer pulling blood into the lower extremities. As a result, venous return to the heart is naturally restored, and there is no longer a need for the compensatory vasoconstriction that was required while standing. But if the patient has taken midodrine, the drug continues to stimulate alpha 1 receptors on the blood vessels regardless of body position. In other words, even though the patient is now lying flat and no longer needs additional vasoconstriction, the blood vessels remain constricted because of the drug. This excessive vasoconstriction further increases total peripheral resistance, causing the blood pressure to rise excessively while the patient is lying down. This condition is known as supine hypertension, and it is the most important adverse effect of midodrine. For this reason, patients are advised to avoid taking midodrine within 3 to 4 hours before bedtime, since they will soon be lying down. Many clinicians also recommend sleeping with the head of the bed slightly elevated, which helps reduce the rise in blood pressure during sleep. Now, let's move on to the alpha 2 agonists. Unlike alpha 1 receptors, alpha 2 receptors are located predominantly on presynaptic nerve terminals and within the central nervous system. As we discussed earlier, activation of these receptors inhibits the release of norepinephrine and suppresses sympathetic outflow from the brain. As a result, sympathetic activity throughout the body decreases, leading to a reduction in heart rate, cardiac output, peripheral vascular resistance, and ultimately blood pressure. The most important alpha 2 agonists that you should know are clonidine, apraclonidine, guanfacine, and methyldopa. Let's begin with the first alpha 2 agonist, clonidine. Clonidine is one of the most important centrally acting antihypertensive drugs. Instead of acting directly on blood vessels to produce vasoconstriction, clonidine acts primarily within the central nervous system, especially in the brainstem. When clonidine reaches the brain, it stimulates central alpha 2 receptors. Remember what these receptors normally do. They act as inhibitory receptors. Their activation suppresses sympathetic outflow from the central nervous system. In other words, fewer sympathetic impulses travel from the brain to the heart, blood vessels, and other organs. As sympathetic activity decreases, the amount of norepinephrine released from postganglionic sympathetic nerve endings also decreases. With less norepinephrine available to stimulate alpha 1 and beta 1 receptors, as a result, blood vessels relax, peripheral vascular resistance falls, the heart beats more slowly, and cardiac output decreases. Together, these effects produce a sustained reduction in blood pressure. At the same time, clonidine also increases parasympathetic vagal activity, which further contributes to the slowing of the heart rate. One interesting point about clonidine is that if it is given intravenously, it may produce a brief transient increase in blood pressure before the blood pressure begins to fall. Why does this happen? Before clonidine enters the brain, it first reaches the systemic circulation where it can stimulate postsynaptic alpha 2 receptors present on vascular smooth muscle. Although alpha 2 receptors are predominantly located presynaptically and within the central nervous system, a small population of postsynaptic alpha 2 receptors is also present on peripheral vascular smooth muscle. Under normal circumstances, these receptors contribute very little to cardiovascular regulation. However, when clonidine is administered intravenously, it briefly reaches a high concentration in the peripheral circulation before entering the brain. During this short period, it can stimulate these peripheral postsynaptic alpha 2 receptors, producing transient vasoconstriction and a temporary rise in blood pressure. However, once the drug reaches the CNS, its central alpha 2 effects predominate, sympathetic outflow decreases, and blood pressure falls. As a result, the blood pressure falls and remains reduced for a much longer period. This initial hypertensive response is usually not seen with oral administration. With oral administration, clonidine enters both the peripheral circulation and the brain as its plasma concentration gradually rises. During this time, activation of the central alpha-2 receptors progressively suppresses sympathetic outflow. As this central sympatholytic effect becomes the dominant action, any weak peripheral alpha-2 mediated vasoconstriction is clinically insignificant and is effectively masked. Therefore, with oral clonidine, we usually observe only the blood pressure lowering effect rather than the initial rise in blood pressure. Now let's discuss the therapeutic uses of clonidine. Its primary and most important use is in the treatment of hypertension. And as we discuss above, since clonidine suppresses sympathetic outflow from the central nervous system, think about what would happen in conditions where excessive sympathetic activity is contributing to the patient's symptoms. In such situations, clonidine can be very useful because it essentially turns down the activity of the sympathetic nervous system. For example, clonidine is also useful in managing withdrawal symptoms associated with opioids, nicotine, and alcohol. To understand this, remember what happens during withdrawal. When a person suddenly stops using these substances, the sympathetic nervous system becomes overactive, producing symptoms such as sweating, anxiety, restlessness, palpitations, tachycardia, and elevated blood pressure. Since clonidine suppresses sympathetic outflow from the brain, it reduces these autonomic symptoms, making the withdrawal process more comfortable. However, remember that clonidine does not treat the addiction itself, it only helps control the sympathetic manifestations of withdrawal. Another important use is in the treatment of attention deficit hyperactivity disorder, particularly in children. Although the exact mechanism is not completely understood, stimulation of central alpha-2 receptors is believed to improve attention and reduce hyperactivity and impulsive behavior. It is often used when stimulant medications are ineffective, contraindicated, or produce troublesome adverse effects. Clonidine can also help relieve menopausal hot flashes. Hot flashes are thought to result, at least in part, from increased sympathetic activity and instability of the body's thermoregulatory center. By reducing sympathetic outflow, clonidine decreases the frequency and severity of these episodes in some patients. So, instead of trying to memorize a long list of indications, remember one simple principle. Whenever excessive sympathetic activity contributes to a disease or its symptoms, clonidine may be beneficial. From this single concept, you can understand why it is used in hypertension, withdrawal syndromes, and several other conditions associated with sympathetic overactivity. Now let's discuss the adverse effects of clonidine. Most of these adverse effects can be understood simply by remembering its mechanism of action. Clonidine suppresses sympathetic outflow from the central nervous system. While this is beneficial for lowering blood pressure, reducing sympathetic activity can also affect several normal physiological functions, leading to predictable adverse effects. One of the most common adverse effects is dry mouth. Normally, sympathetic stimulation helps regulate salivary gland function. Since clonidine decreases sympathetic activity, salivary secretion is reduced, causing patients to experience dryness of the mouth. Another very common adverse effect is sedation or drowsiness. Remember, clonidine acts within the brain. By reducing neuronal activity in central sympathetic pathways, it also produces a calming effect on the central nervous system. As a result, many patients feel sleepy or less alert, especially during the initial weeks of treatment. Fortunately, this sedation often becomes less noticeable as the body gradually adapts to the medication. Because clonidine decreases sympathetic stimulation to the heart and simultaneously increases vagal activity, the heart rate may slow down. In some patients, this slowing is excessive, resulting in marked bradycardia. Therefore, clonidine should be used cautiously in patients who already have a low heart rate or conduction abnormalities. Some patients may also experience sexual dysfunction. Since clonidine suppresses sympathetic outflow, it can interfere with the emission phase of ejaculation, leading to delayed ejaculation or reduced ejaculation. Some patients may also experience reduced libido or erectile problems due to central nervous system effects. But the most direct autonomic effect is on ejaculation, because ejaculation is a sympathetic function. One particularly important adverse effect to remember is rebound hypertension after abrupt discontinuation of clonidine. Imagine a patient has been taking clonidine for several weeks or months. During this time, the sympathetic nervous system has been continuously suppressed. If the drug is suddenly stopped, this inhibitory effect is removed all at once. The sympathetic nervous system becomes excessively active, causing a sudden surge in norepinephrine release. As a result, blood pressure can rise rapidly, sometimes even exceeding the patient's original blood pressure before treatment. This phenomenon is known as rebound hypertension. Therefore, clonidine should never be stopped abruptly. Instead, the dose should be reduced gradually to allow the sympathetic nervous system to readjust. Finally, when clonidine is administered as a transdermal patch, some patients may develop contact dermatitis, which presents as redness, itching, or irritation at the site where the patch is applied. So, rather than memorizing the adverse effects individually, remember the underlying principle. The next alpha-2 agonist is apraclonidine. Although it belongs to the same class as clonidine, its clinical use is quite different. Instead of treating hypertension, apraclonidine is used topically as an eye drop to reduce intraocular pressure, particularly in patients with glaucoma. To understand how it works, let's first recall the physiology of aqueous humor. As we discussed in the previous lecture, the ciliary epithelium continuously produces aqueous humor, which flows through the posterior chamber, passes into the anterior chamber, and finally drains through the trabecular meshwork and the canal of Schlemm. Normally, the rate of aqueous humor production is balanced by its drainage, maintaining a normal intraocular pressure. In glaucoma, however, this balance is disturbed. Either too much aqueous humor is produced, or, more commonly, its drainage is impaired. As a result, intraocular pressure rises, which can gradually damage the optic nerve and lead to irreversible vision loss if left untreated. Apraclonidine helps lower intraocular pressure primarily by stimulating alpha-2 receptors on the ciliary body, which reduces the production of aqueous humor. As less aqueous humor is formed, the amount of fluid inside the eye decreases, causing intraocular pressure to fall. Some studies also suggest that apraclonidine may slightly increase uveoscleral outflow, but its main mechanism is the reduction of aqueous humor production. Unlike clonidine, apraclonidine has minimal systemic effects because it is applied directly to the eye and does not readily cross the blood-brain barrier. Therefore, it does not significantly suppress central sympathetic outflow or produce the sedation, dry mouth, or hypotension that are commonly associated with clonidine. Clinically, apraclonidine is mainly used as a short-term adjunctive treatment in patients whose intraocular pressure is not adequately controlled with other anti-glaucoma medications. It is also commonly administered before or after laser procedures, such as laser trabeculoplasty or laser iridotomy, to prevent the temporary rise in intraocular pressure that can occur after these procedures. The next alpha-2 agonist is methyldopa. Like clonidine, methyldopa is also a centrally acting antihypertensive drug, but there is one important difference in how it produces its effect. Unlike clonidine, which is itself an active alpha-2 receptor agonist, methyldopa is a prodrug. So, after entering the brain, methyldopa undergoes metabolism and is converted into its active metabolite, alpha-methylnorepinephrine. It is this metabolite that acts as the actual alpha-2 receptor agonist. Once alpha-methylnorepinephrine is formed, it stimulates the central alpha-2 receptors in the brainstem. Similarly, their activation suppresses sympathetic outflow from the central nervous system. As a result, less norepinephrine is released from sympathetic nerve endings, leading to less stimulation of alpha-1 receptors on blood vessels and beta-1 receptors in the heart. Consequently, peripheral vascular resistance decreases, the heart rate slows, cardiac output falls, and blood pressure is reduced. So, apart from the fact that methyldopa is a prodrug, its mechanism of lowering blood pressure is essentially the same as that of clonidine. The next alpha-2 agonist is guanfacine. If you already understand clonidine, then guanfacine is very easy to remember because its mechanism of action is essentially the same. One important difference is that guanfacine is more selective for alpha-2 receptors than clonidine. This greater selectivity helps it produce its therapeutic effects through central alpha-2 receptor activation while minimizing unwanted actions on other adrenergic receptors. Clinically, guanfacine is used to treat hypertension, but today it is more commonly recognized for its role in the treatment of attention deficit hyperactivity disorder, particularly in children and adolescents. In ADHD, stimulation of central alpha-2 receptors improves attention, reduces impulsivity, and helps control hyperactive behavior. For this purpose, an extended-release formulation of guanfacine is commonly prescribed because it provides a more sustained therapeutic effect throughout the day. The adverse effects of guanfacine are also very similar to those of clonidine. Since both drugs suppress sympathetic activity, patients may experience sedation, dry mouth, and bradycardia. However, one practical advantage of guanfacine is that it has a longer duration of action than clonidine. Because the drug leaves the body more slowly, abrupt discontinuation is less likely to produce severe rebound hypertension. Although a withdrawal syndrome can still occur if the drug is stopped suddenly, it is generally less frequent and milder than that seen with clonidine. The next drug is oxymetazoline. Unlike the drugs we have discussed so far, oxymetazoline is not a selective alpha-1 or alpha-2 agonist. Instead, it directly stimulates both alpha-1 and alpha-2 adrenergic receptors. However, its most important clinical effect is local vasoconstriction, which is why it is commonly used as a topical nasal decongestant. As we discussed above, when oxymetazoline is sprayed into the nose, it directly stimulates alpha adrenergic receptors on the blood vessels of the nasal mucosa. This produces vasoconstriction, reducing blood flow to the swollen tissue. Consequently, the patient experiences rapid relief from nasal congestion. Oxymetazoline is also available as ophthalmic eye drops. In the conjunctiva, it produces vasoconstriction of the superficial blood vessels, reducing redness associated with minor eye irritation, allergies, or contact lens use. Now you might ask, if oxymetazoline also stimulates alpha-2 receptors, why doesn't it lower blood pressure like clonidine? The answer is that oxymetazoline is used topically and has minimal penetration into the central nervous system at therapeutic doses. Therefore, its peripheral vasoconstrictor effect predominates, and it does not produce the central antihypertensive effect as seen with clonidine. Although oxymetazoline is intended for local use, a small amount may still be absorbed into the systemic circulation. In some patients, this can produce adverse effects such as nervousness, headache, insomnia, or an increase in blood pressure, particularly if excessive amounts are used. Finally, one of the most important adverse effects to remember is rebound nasal congestion, also known as rhinitis medicamentosa. Suppose a patient uses oxymetazoline for several days. Initially, vasoconstriction effectively relieves nasal congestion. However, with continuous use, the alpha adrenergic receptors become less responsive and the blood vessels lose their ability to maintain vasoconstriction. When the effect of the drug wears off, the blood vessels dilate excessively, producing even greater nasal congestion than before. The patient then uses the spray again for relief, creating a vicious cycle of repeated use and worsening congestion. For this reason, oxymetazoline should generally not be used for more than 3 to 5 consecutive days. Finally, let's briefly discuss moxonidine. Like clonidine, moxonidine is also a newer centrally acting antihypertensive drug that reduces sympathetic activity and lowers blood pressure. However, there is one important difference between the two drugs. While clonidine primarily acts by stimulating central alpha-2 receptors, moxonidine acts mainly by stimulating imidazoline I1 receptors in the brainstem. It has only a weak action on alpha-2 receptors. Despite acting on a different receptor, the final outcome is essentially the same. Activation of the imidazoline I1 receptors suppresses sympathetic outflow from the central nervous system. As fewer sympathetic impulses travel to the peripheral organs, less norepinephrine is released from sympathetic nerve endings. Consequently, there is reduced stimulation of alpha-1 receptors on blood vessels and beta-1 receptors in the heart. This causes peripheral vascular resistance to decrease, heart rate to slow slightly, and blood pressure to fall. Because moxonidine is much more selective for imidazoline I1 receptors than for alpha-2 receptors, it generally produces less sedation and dry mouth than clonidine, while still providing an effective antihypertensive action.